Good morning. For those of you who are still on the line, thank you for your patience. We obviously had some technical difficulties here, so we'll go ahead and get started. I do want to let you know my name's Kim Wilcoxon. This is a Thompson Hine sponsored webinar, and I'm co-presenting today with Beth Mandel. Beth will be assisting with the presentation and monitoring your questions. And today we're going to cover aspects related to health and welfare plans. This webinar is the fourth in a series of webinars that we're doing. The fifth and final webinar is next Thursday, September 27th, and we'll cover retirement plans. You can register for that last webinar through the same invitation you used to register for today's presentation. You can also apply for CLE or HRCI credit. There's an attorney affirmation form in the handout section. You may want to download it now and keep it handy. We'll give you the code you need to complete the form at the end of the webinar. Feel free to use the question panel to submit questions at any time during the presentation. We'll answer questions at the end of the webinar as time allows, and we'll try to condense the presentation to fit the time we have left. But feel free to submit on the question panel. Any questions we don't answer during our time together today will be responded to via email after the webinar. So let's go ahead and jump in. Today we're going to talk first about some recent guidance that's been issued impacting health and welfare plans. Then we'll discuss some guidance we expect to see in the near future. We'll go over some state-based employer mandates or reporting obligations, and then round out with some 2020 planning considerations so that you can make sure you've thought of a bunch of different things before you enter into the open enrollment season. So recent guidance. First item is IRS Notice 2019-45, which was issued on July 17th, 2019. This guidance provides permissive guidance, but doesn't actually require any changes to your high deductible health plan. So the background on this is that a high deductible health plan, an individual must be enrolled in a high deductible health plan in order to be eligible to contribute to an HSA. So that an individual needs to be in a high deductible health plan and can't be in any other disqualifying coverage. Now we know from past guidance that if an employer or a health plan pays for pretty much any medical care before an individual reaches their deductible, that individual is not in a qualifying high deductible health plan. So the plan or the employer is allowed to pay for preventive care or for coverage for dental care, vision care, long-term care, accidents, or disability. But anything else that's paid before the deductible would disqualify the plan. Typically, in a major medical plan, the only thing that can be paid before the deductible is preventive care. What do we mean by preventive care? Well, it has different meanings for different contexts. For a high deductible health plan, preventive care are services that a high deductible health plan may, but is not required to cover before an individual reaches their deductible. Now, by contrast, the Affordable Care Act has a set of preventive care services and items and drugs that a non-grandfathered plan must cover at 100% when done in network. So the ACA is mandatory. You must cover these things that are considered preventive care at 100%. Now, the high deductible health plan rules, thankfully, allow us to cover that subset of preventive care under the high deductible health plan preventive care rules. But there also may be some items and services outside of the ACA bubble that we can include as preventive care and pay at 100%. That's the focus of this notice. Now, before we received this notice, essentially, we were allowed to cover under a high deductible health plan, ACA preventive care, as I just mentioned, services that qualify as preventive under the Social Security Act, and preventive care as defined in IRS guidance. So we have some prior pieces of guidance that essentially said, if you have a medical condition that's resolved itself, and you're taking a drug to prevent recurrence of that condition, that's fine. That drug can be considered preventive care. Or if you have a condition that hasn't yet developed, and you're taking a drug to prevent that condition from developing it, that's fine. It can be considered preventive care. But generally, anything else used to treat an existing condition, the IRS has indicated is not preventive care. In this notice, the IRS went one step further at the instruction of an executive order to identify certain items and services that can be used to treat a chronic condition and still be considered preventive care. The notice contains a list that's on the slide right here of the items or services that can be covered and the condition for which that item or service can be considered preventive care. So this is not to say that all, let's say, low-density lipoprotein testing can be covered as preventive care. It can only be covered for preventive care when done with respect to heart disease, to prevent the heart disease from exacerbating or to prevent a secondary condition from developing. So there's some limitations on even this list on the left side of the chart. Now, is this chart the end-all be-all? Is this the only thing that's considered preventive care? If you read the notice closely, it appears to say that the answer is yes. So I've included on this slide some excerpts from the notice where you'll see, these medical services and items are limited to the specific medical care services or items listed in the attached appendix for the chronic conditions specified in the appendix. This notice does not expand the scope of preventive care beyond this list. Therefore, services or items that meet or may meet the criteria that the IRS used to develop the list, but are not on the list, may not be treated as preventive care as a result of this notice or on any other basis. But any services and items that constitute preventive care under prior IRS guidance continue to be treated as preventive care. So what does all this mean for an employer? Well, you'll want to think about whether to expand your definition of preventive care under your high deductible health plan to include this chart. You'll want to talk with your TPA if you've got a self-funded plan, or an insurer if you've got a fully insured plan, because there's some administration that will be required as a result of implementing this notice. So your TPA may not be ready to do this. It's worth a conversation with the TPA. Then you'll also want to check to see, does your SPD need to be updated? Is a plan amendment required? What does the language of your document currently say? Would it encompass these new items and services if you do want to add them as preventive care? And if not, you may need to do some updates. And you may need to update your participant communications, because if you do add these items or services, it may be confusing for a participant who sees that something can be covered at 100%, but then they actually get a bill for it. Well, it's because it wasn't prescribed for this particular condition that was described in this notice. So there may be some communication required. And you're going to want to consider the extent of your TPA or your PBM's preventive drug lists. So historically, we've seen pharmacy benefit managers come up with these lists of preventive care drugs that when you look at it, it sure seems like some of the drugs on that list could be used to treat existing conditions, which we knew prior to this notice, the IRS didn't think you could do. Or at least that's what we heard from the IRS whenever the question was asked. But the IRS never came out and said these preventive drug lists are wrong. We've never seen any enforcement on it. So given what we just saw about the notice being exclusive, does that mean that these more expansive prescription drug lists, that the preventive care list, does that mean that they are not permissible? It's a good question. It's one that's being debated in the industry, and maybe we'll see some guidance on it. As of right now, there's a risk based on the language of the notice, but it's worth, again, a conversation with your PBM to see what they're thinking, what they're doing, and how you want to address that. So I'll turn it over to Beth now.
All right. Hi, everyone. So turning now to the topic of exclusions of drug manufacturer coupons from out-of-pocket maximums. As the prevalence of drug manufacturer coupons has increased, plans have struggled with how to address and how to account for those coupons. Should those coupons be credited toward participants' deductibles and out-of-pocket limits, or should they be excluded? There are pros and cons to both approaches. Some believe that crediting the coupons will encourage participants to fill prescribed medication that they may not otherwise be able to afford, and that will over time lead to healthier outcomes and decrease costs to the plan. Others believe that crediting coupons toward the deductible and out-of-pocket limits essentially lets participants double dip and encourages participants to purchase expensive brand name drugs despite the availability of less expensive generic alternatives. So earlier this year, to address some of these questions, HHS issued proposed rules which were finalized in April, addressing the application of the ACA cost-sharing limitations with respect to brand name prescription drugs and drug manufacturer coupons. For background, the ACA limits the amount that participants can be required to pay out of pocket each year for in-network essential health benefits. For 2019, the max annual limit is $7,900 for self-only coverage and $15,800 for family coverage. The final rules issued by HHS in April of this year amend regulations implementing those cost-sharing requirements to address drug manufacturer coupons. And under the new rule, which is effective for plan years beginning in January 1st, 2020, although that effective, or at least the enforcement of that, will be delayed, as we'll talk about in a minute, when drug manufacturer coupons are used to purchase brand drugs, plans are permitted to exclude the value of those coupons from counting toward the participants' out-of-pocket maximum if and when a medically appropriate generic is available. The rule is permissive, so again, plans don't have to exclude the value of the coupons from the out-of-pocket max, but they may do so under the described scenario. So after the rule was issued, a number of questions arose. There was confusion and debate over how to interpret the rule with respect to other scenarios. For example, when a coupon is used for a brand drug for which no generic equivalent is available. Language in the preamble to the final rule suggested that in all other scenarios involving drugs that qualify as essential health benefits, plans would be required to count the coupon toward the out-of-pocket max. But many expressed doubt that HHS intended that result. So, these questions were circulating. And then questions also arose as to how this requirement would work with respect to HDHP health plans, whether the rule would impact HDHP participants' ability to contribute to an HSA. Specifically, there were questions as to whether drug manufacturer coupons, if credited towards a participant's deductible, were considered impermissible disqualifying coverage that would disqualify somebody from HSA eligibility. So plan administrators were concerned that the new cost-sharing rule would put them in the position of having to basically exclude coupons from the deductible accumulation, but then count those same coupons toward the out-of-pocket max accumulation. Obviously, that can be pretty difficult to implement. So due to the questions surrounding the interpretation of the drug coupon rule, last month HHS issued an FAQ announcing that it would delay enforcement of the rule. Specifically, HHS indicated that it plans to issue further guidance in the forthcoming Notice of Benefit and Payment Parameters for 2021, and that enforcement of the drug manufacturer rule would be delayed until the 2021 notice is issued and effective. So where do we stand on coupons now? Well, we know there will be no enforcement with respect to plans crediting or not crediting coupons toward the out-of-pocket maximum. However, we still lack clarity on application of coupons to deductibles. And in fact, language in the recent FAQ, which I've excerpted for you here, indicates that HHS interprets prior guidance on HSAs to require HDHPs to exclude or disregard drug coupon amounts in determining whether the deductible has been met. That earlier HSA guidance stated that that drug discount cards that entitled holders to obtain discounts for healthcare services or products at managed care market rates will not disqualify an individual from being an eligible individual for HSA purposes if the individual is required to pay the costs of the healthcare, taking into account the discount until the deductible of the HDHP is satisfied. But if you look at this language that I've excerpted for you, it looks like now HHS is interpreting that guidance to go much further, to essentially require HDHPs to exclude the amount of drug discounts and other manufacturers and providers' coupons from counting toward deductibles. So now we're left with the question of what are plans to do in light of this guidance. And generally, we're kind of in limbo right now, but what we're recommending is that plans take steps right now to basically find out what your plan is doing if you're not aware. So you should determine the extent to which the plan does or should exclude drug manufacturer coupons from the out-of-pocket maximum. Find out what your TPAs are doing. Find out how they're tracking these drug manufacturer coupons and how they're accounting for them. For high deductible health plans, determine the extent to which the plan does or should exclude the coupons from the deductible. And then you'll also want to ensure that your SPDs and other communications clearly communicate how drug manufacturer coupons are treated under the plan so that there isn't confusion amongst your participants.
Okay. Right. Thanks. We'll turn now to mental health parity FAQs. These were issued in response to the 21st Century Cures Act, which was passed at the end of 2016, right at the end of the prior administration, to essentially direct the Department of Labor to provide more information and guidance on compliance with the mental health parity rules. So in 2018, the IRS came out with these proposed FAQs, actually the tri-agencies did, to attempt to explain how the mental health parity rules would apply to a variety of circumstances. They issued them as proposed FAQs. It's the first set of FAQs that they've ever issued as proposed. And so they just recently finalized them. Unlike regulations, where they propose regulations and then when they finalize them, there's a nice preamble where they go through all the considerations that they put into it. What comments did they receive? Why did they decide to do what they did in the final? We didn't have any of this in the final FAQs. We just have the final FAQs. Now, in most cases, the FAQs were finalized substantially as proposed. There was some clarifying language to make sure that any questions that were asked as a result of the FAQs really were answered. But substantively, there were no changes from what we saw in 2018. There was one FAQ, though, that was withdrawn, and that was with regard to a question that said, you know, I'm in the emergency room, or I've got an issue with an emergency room service, and it's treating a medical issue that was caused by a mental health condition. Is that a mental health service for purposes of the mental health parity rules, or is it a medical service for purposes of the mental health parity rules? And the proposed answer was, well, if you're treating the medical issue, it's a medical service. There were a number of questions that came about as a result of that FAQ, at least with administrators that I talked with. You know, can you apply that FAQ in situations outside of the emergency room? Does that mean if I'm doing physical therapy for something that's generated by a mental health condition that I can consider that a medical benefit? None of those questions were answered, and just the FAQ was withdrawn without comments. We don't really understand the significance of that. What is interesting is several of these FAQs focus on a situation where administration differs from the plan document. So the plan document appears to be written in a compliant way, but the administration is different. You know, our plan document says we treat these things as experimental, but in operation, we use that criteria for medical services, but we use more strict criteria for mental health services. Well, obviously that's a problem. And so several of these FAQs focus on administration that differs from a compliant plan document. Along with the FAQs was issued a report by the Department of Labor where they talked about their enforcement statistics for the past fiscal year. And they said essentially in this report, now you may look at this and see that our statistics have gone down, but really what we've done is chosen to focus our time on situations where we could impact the most people. So we may not have closed as many cases as we did in prior fiscal years, but we went after situations where there was an issue by an administrator or an insurer that impacted all of their clients. And we got the administrator to change the way they do this for all of their clients. So that, combined with the FAQs, tells us that administration is a focus of the Department of Labor under the mental health parity enforcement. And so you can know that your plan is designed in the right way. You can run testing. You can look at the non-quantitative treatment limitations. But what you don't know is whether your administrator is actually administering the plan in accordance with your plan document. Other FAQs focus on the non-quantitative treatment limitations, and I want to take just a minute on this. Under the mental health parity rules, something that's a non-quantitative limit, so if it's a 20 visit limit, if it's a copay, those are things that involve numbers that we can run numerical tests on to see if they satisfy the mental health parity rules. Then we have these more amorphous limits like pre-authorization requirements or what's considered experimental or investigational. Those aren't things that we can run numerical tests on. So the rules say that the processes, the strategies, the evidentiary standards that you use to apply the limitation to mental health services have to be comparable to and applied no more stringently than those same ideas applied to the medical services. So essentially, if you're going to have a limitation on mental health services, you have to say why. Why do we have this limitation? How did we come up with it? What's the criteria that we used? And is there something on the medical side that's analogous to the mental health service? If we apply that same criteria, is there anything on the medical side that's being denied? So what does all of this mean for your plan? Well, you really need to understand what non-quantitative treatment limitations apply under your plan, and then understand why. If it comes down to it, if it comes down to litigation, if the Department of Labor asks, you have to be able to say, why did we put this in place? And if we apply that same thought on the medical side, what are we excluding on the medical side? A lot of times the non-quantitative treatment limitation may not have been something you specifically intended to do. It may have been handed to you as a package from your administrator. They gave you an SPD that explains which services are subject to prior authorization. You didn't specifically go through and say, I want to include this, I don't want to include this. Now, you may have for certain things, but you may not be able to answer the question why. And so you may need to go back to your administrator and be prepared to do that. You also may consider requesting confirmation of operational compliance, since that seems to be a focus of the Department of Labor. You know, if your administrator is violating the Mental Health Parity Act with respect to your plan, it's your plan that's responsible for the violation, not the administrator. So you may also consider contractual provisions to protect your plan in the event that the administration is in fact inconsistent with plan design. And our last item of recent guidance is final HRA regulations. We don't think these will be of interest to many of the folks on this call, but wanted to at least touch on them so you knew enough to say, yes, I'm definitely not interested, or maybe I want to find out more about that. So the final HRA regulations gave us two new types of HRAs that we can offer to our employees. The first is an individual coverage HRA. And so this HRA essentially lets you give money to your employee on a non-taxable basis that they can use to go out and purchase insurance on the individual market. Now, it can also be used to reimburse for any other 213D medical expenses, but the highlight here is that you can use it for individual health insurance. The kicker, though, is that you can't also offer a group health plan to anyone who's eligible for an individual coverage HRA. So you could not offer a package to your employees that says you may choose individual coverage HRA or group health plan. You have to decide yourself, I'm either going to offer the group health plan or the individual coverage HRA. And if you make that decision, you have to offer the group health plan or the individual coverage HRA to all members of a permitted class. So here are the permitted classes. An example is you could offer a traditional group health plan to all of your full-time employees or ineligible full-time employees, and you can offer an individual coverage HRA to your part-time employees. You could not, though, say, I'm going to offer a traditional group health plan to my my corporate staff employees and an individual coverage HRA to my in-store employees. That's not a distinction that's a permitted class here. You have to draw the lines based on the classes that are here. So that may not make the individual coverage HRA as attractive to folks who want to continue to offer a group health plan to their employees. The other type of HRA that's been added is an accepted benefit HRA. And really, this is just a pot of money that you can give your employees to reimburse medical expenses without having to jump through all the integration hoops. Now, it's a limited pot of money. It can't be more than $1,800, and that would be adjusted in the future. It's got to be offered to all similarly situated individuals, so we don't have to offer it on the same class lines that we would do for an individual coverage HRA, but it couldn't be used to reimburse individual insurance premiums. It could be used for COBRA, it could be used for Medicare Part D, but it couldn't be used for group health plan premiums or for individual coverage premiums. All right, so let's move on now to some guidance that we are expecting to see in the relatively near future.
All right, so we're talking first about the forthcoming FSA guidance, and you'll want to keep an eye out next year for this guidance. It should be coming out around or prior to March 21st, 2020. Basically, Executive Order 13877, this is the same executive order that addressed or prompted the Preventive Care guidance, directed the IRS to propose regulations to treat certain types of healthcare arrangements as eligible medical expenses under Code Section 213D. We might see regulations coming out in connection with that direction that would address arrangements like concierge medical programs and other emerging models of healthcare delivery. The order also directs the IRS to issue guidance increasing the FSA carryover limit, which I expect will be welcome to many plan sponsors and participants. And then moving on to the next item, we have a trio of cases that have been appealed to the Supreme Court. The question that the Supreme Court will be addressing is whether Title VII prohibits discrimination against transgender individuals based on their status as transgender. And we're expecting a decision from the Supreme Court in or before July 2020. This ruling is likely to have an impact on group health plan design, specifically with respect to coverage for gender transition services. So definitely something to keep an eye on. Make sure you're aware of what your current plan design is and think about what kind of changes you might need to implement.
And then last but not least for upcoming guidance this morning is wellness program regulations. So we are still in wellness program limbo. I'm sure you're familiar with this background, but just wanted to level set. We had ADA and GINA applied to the wellness program. And we know that those rules require a wellness program to be voluntary. EEOC regulations issued in 2016 gave us a safe harbor for financial incentives. If you offer X dollars to a participant to complete a program, does that make the program involuntary? Because you're penalizing the people who didn't complete the program and therefore don't get the money. EEOC regulations had a 30% safe harbor. If you go up to that, you're fine. Above that, you would need to justify it. The EEOC then was sued, arguing that they did not think through their regulations and that 30% limit, and so that 30% limit should not be valid. The court agreed with AARP, who sued the EEOC, and vacated those incentive limits as of 1/1/19. So the EEOC complied and pulled that out of their regulations. Similarly, GINA, the Genetic Information Non-Discrimination Act, prohibits offering incentives for genetic information except with respect to voluntary wellness programs. Now, but GINA just flat says you can't offer an incentive for genetic information. Genetic information is defined to include the manifested medical conditions of your family members, which makes sense if my father has a hereditary disease. You know that he has that disease. You know there's a good chance that I could get that disease. So in that case, it makes perfect sense that the manifested medical condition of my family member would be considered my genetic information. But the definition of family member includes a spouse. Now, hopefully, my spouse does not have any sort of influence on my own medical condition. If so, then we've probably done something wrong. But that's the way that the law is written. And so theoretically, under GINA, there is a violation of GINA if you incentivize an employee for providing their spouse's medical information. Hence, a incentivized spousal HRA theoretically could violate GINA. We had regulations in 2016 that said it was fine to do it if you followed these rules. Those incentive regulations have now been withdrawn. So technically, we may have a violation of GINA if we incentivize a spousal HRA. We may have a violation of the ADA if we provide any incentive for a wellness program. We just don't have a good safe harbor from the Department of Labor, or excuse me, the EEOC, to tell us what's okay and what's not okay. So plan considerations, at this point, we are expecting regulations in the relatively near future. And I want to put relatively in quotes because we just don't know. For a while, we didn't have an EEOC commissioner. They couldn't get one, confirmed. We didn't have a quorum in the EEOC. We do now have a quorum at the commission. We've got a commissioner. So they should be able to proceed in writing rules. They've said they want to issue them by the end of the year. We'll see if that actually happens. But they're definitely not going to get anything out in time for you to plan for 2020. So you really just have to take a look at the incentives that you offer under your wellness program and decide about your risk tolerance. If your incentives are up at that 30% level, you probably have a higher risk than if your incentives are down more closer to 5%.
All right, so turning to the topic of state mandates and reporting requirements. So after the ACA individual mandate was repealed, then several states have stepped in to implement their own individual mandates. They liked the idea, they wanted to continue it. So we now are in a situation where we have several states that have individual mandates in place and reporting requirements, if not already, if they haven't already started, they're going to be starting fairly soon. So currently the states that have adopted individual mandates are Massachusetts, which of course had the mandate in place prior to the ACA, and then now basically that mandate is just has returned and is still in place. And then we have New Jersey, DC, California, Rhode Island, and Vermont. Most of the states mirror the ACA individual mandate provisions, which is helpful because then it allows similar or the same forms to be used to report in those states. So New Jersey, the New Jersey individual mandate, again, like I just said, mirrors the ACA individual mandate. It imposes a penalty on New Jersey residents who fail to obtain minimum essential coverage. The reporting requirement applies to employers with New Jersey residents, and that's important because in some cases reporting is only required if you have employees in the state or you actually employ people in the state, but in this case it's if you have any employees who reside in New Jersey. So if you fall into that category, you have to file 2019 coverage information by March 31st, 2020. You can use the federal ACA reporting forms, and we've included a link where you can find additional information on this. The DC individual mandate, again, also mirrors the ACA individual mandate, imposes a penalty again on residents who fail to obtain MEC. Reporting is required for employer sponsors of group health plans that covered at least 50 full-time employees, including at least one DC resident during the applicable calendar year. If you fall into that group, you have to file 2019 coverage information by June 30th, 2020. You, again, can use the federal ACA reporting forms, and we've included a link again for more information. Massachusetts reporting. So we talked about the fact that the Massachusetts mandate predates the ACA, and that requires employers to provide the form 1099-HC to each employee who resides in Massachusetts. The forms must be provided by January 31st, and you also have to submit forms to the Massachusetts Department of Revenue. This applies to employers who offer self-insured coverage or coverage issued by non-Massachusetts insurance carriers. And then additionally, there's a requirement for employers to file a health insurance responsibility disclosure, or a HRD. This applies to Massachusetts employers with 6 or more employees, regardless of whether they offer health insurance. It's an annual filing due November 30th of each year. It began in 2018, and a new form was actually issued in 2018, so make sure that you're using the correct form when you go to file. And we've included more information or a link to more information as well on this.
And just a note there used to be something called a HRD form back before the ACA. Beth mentioned that this is a new form. It's a completely new concept, actually. So if you thought you did a HRD way back when, and you know it's different now. So just be aware that is different. All right, moving on to San Francisco. There's no change to the law here. San Francisco has their healthcare security ordinance, their employer spending requirement. This applies to any employer who is required to have a business registration certificate in San Francisco. If you have at least 20 employees, but at least one works in San Francisco. So you only need one employee in San Francisco, but you also need to be required to have a business registration certificate there. If that's the case, then you're required to spend a certain dollar amount on healthcare for your employees. If you offer a group health plan to your San Francisco employees, then you need to determine the value of the coverage that's being offered to that individual. The amount that you need to spend on the individual depends on the number of hours that they work. So there's been an update for there's an update every year on the amount per hour. For large employers for 2019, it was $2.93 an hour. That's been increased for 2020 to $3.08 per hour. So you would need to determine how many hours your San Francisco employees are working, and does the value of your health coverage reach the level of spending that's required for those San Francisco employees? If so, then you're fine. You don't need to do anything else from a spending perspective. If not, then you need to figure out another way to get money to those individuals. And there are some options that are available to you, but they've got to be non-forfeitable, and you can pay into the city of San Francisco to do your excess. Now, if an employee is offered your health coverage but waives it, you still are required to spend for that employee unless they sign a San Francisco waiver form. So there are some requirements in order to be an authorized waiver form. It's not just choosing not to enroll in the plan. Now, if it were me, I don't know why I would ever sign that form if signing the form means I don't get free money from my employer, but maybe some people do. So the update for this year is the update in the amount. So when you're planning for 2020, you just want to know whether the cost of your health coverage is going to satisfy that spending requirement. There has been no change to the annual reporting. There's an annual report that's due every April 30th. No change to that requirement.
All right, so we know that this is not health plan related, but we wanted to make sure that you're prepared for the new New Jersey transit mandate, given that this has been considered a hot topic for a lot of the employers who we work with. So effective March 1st, 2020, or if different, the date specified by forthcoming guidance, employers are going to have to offer pre-tax transportation benefits to New Jersey employees. This would include commuter highway vehicle benefits, transit passes, qualified parking, and the pre-tax benefit has to be provided at the maximum benefit levels permitted under federal law. This requirement applies to all employers that are subject to New Jersey unemployment compensation law and who employ 20 or more persons.
And I'll say we don't have any guidance on this yet, and I have a number of questions about how it applies. So there's a distinction in the law between the term employee and the term person, and it's not clear to me whether the 20 have to be New Jersey employees or whether it's 20 total and just, you know, whoever's in New Jersey has to be offered the transit benefits. So we're hoping to see some guidance on this that may explain more about exactly how it applies and which employees are required to be offered the benefit. So plan considerations for all of these state-based requirements. Number one, you want to know what state mandates are applicable. And I will say that we haven't addressed all of the state or local mandates in this presentation. There are state mandated disability rules. There are some local transit requirements. So you'll want to understand what states your employees live in, what states your employees work in, you know, what localities they live and work in, so that you can understand which mandates are going to apply. And then, of course, you need to make sure you are complying. So if you have a self-funded health plan, or if you've got an insured health plan and your insurer is not licensed in the state of Massachusetts, you want to make sure you know who is sending those forms 1099-HC. If the TPA or the insurance company is not doing it, then it's the employer's responsibility. So you got to make sure you know that that's being done. You want to also confirm who will complete the Massachusetts HERD filing. Typically, this is something that employers really have to do because they have to go in through their Massachusetts tax login and to provide information about the health plan. We've not seen TPAs be able to do that. You also want to talk to your ACA reporting vendor. Given that New Jersey and DC are requiring filings of the ACA reporting forms, will your ACA reporting vendor be willing to submit those forms on your behalf? And of course, you want to confirm whether your health plan is rich enough to satisfy the San Francisco spending requirements. And you want to consider adopting a transit benefit program if you've got New Jersey employees. Or if you already have a program in place, review it to make sure it complies with the New Jersey requirements. Like I said, we don't have guidance yet. And I do want to point out that the effective date on this is the earlier of March 1, 2020, or the date specified in guidance. But if you've got employees under a collective bargaining agreement, you can wait until the expiration of the bargaining agreement that was in effect on March 1, 2019. So if you're coming up on negotiations before 2020 or whenever you come up on negotiations, you may want to address transit benefits. And then, of course, you want to confirm that any other aspects of state or local mandate compliance are being addressed. So that takes us then to thoughts for 2020. Beth?
All right, and so the first issues that we wanted to make you aware of are just the 2020 adjustments, so the normal adjustments we see on a year-to-year basis. The affordability percentage is going to 9.78%. It's actually down this year from 9.86%. The out-of-pocket max, it may not exceed $8,150 for self-only coverage or $16,300 for family coverage for plan years beginning in 2020. HDHP.
And let me stop you right there. So the out-of-pocket max, remember this one has to have the embedded out-of-pocket max. So it's $8,150 per person. If you have a family out-of-pocket max that's $9,000 and you have one individual who reaches $8,150, the plan has got to start covering that person's expenses at 100% under the essential health benefits, even though the family, they're in family coverage and the family out-of-pocket maximum hasn't been met yet. That's different than the high deductible health plan rules that Beth's going to talk about next.
All right, thanks, Kim. So for the high deductible health plans, the deductible must be at least $1,400 or $2,800 for family coverage for plan years beginning in 2020. Again, that's up from this current year. The out-of-pocket max must not exceed $6,900 self-only coverage or $13,800 family coverage for plan years beginning next year, 2020. Again, up from this year. The maximum HSA contributions are also increased slightly to $3,550 and then $7,100 for family coverage. And then finally, the healthcare FSA. We don't yet know what the limit will be for 2020. Unfortunately, it seems like the IRS never announces this limit until half of the employers who we work with have gone through their open enrollment. So stay tuned for that.
Then some things to think about from a plan design perspective. For 2020, this is an issue that impacts only high deductible health plans. We talked about the fact that high deductible health plans can't pay for anything other than preventive care before an individual reaches their deductible. Well, there was a guidance put out by the IRS back in 2018 that said, we understand there are some state insurance laws that require fully insured plans to cover male sterilization and male contraceptives at 100%. And that's because the Affordable Care Act, in their required preventive care, requires female contraceptives and sterilization to be covered at 100% as preventive care. Now, the ACA doesn't require the same for male sterilization and contraceptives. And some states believed that that was gender discrimination. And so they required their fully insured plans to also cover male sterilization and contraceptives at 100%. Well, the IRS came out and said, yeah, but we don't consider male sterilization or male contraceptives to be preventive care under the high deductible health plan rules. So states, you have until 2020 to get your act together, amend your rules, and allow fully insured plans to impose cost sharing on those services. So if it's probably not an issue for self-funded plans. I've never seen a self-funded plan. I take that back. I've seen one self-funded plan that actually covered this at 100%. But for your high deductible health plans for 2020, you're going to want to make sure that if you cover male sterilization or male contraceptives, that you do impose cost sharing on those before an individual reaches the deductible. Next, if you're adding any annual or lifetime limits, you're going to want to think about those essential health benefit rules. And it's entirely possible that you have not thought about this since 2014 when the Affordable Care Act was starting to be implemented. But you can't impose annual or lifetime dollar limits on any essential health benefits. To determine whether you've got an essential health benefit, you have to refer to a state benchmark plan. So there are plans out there that are examples, and you can pick any state plan. It doesn't have to be the state that you're in. But that plan, if it covers something, it's an essential health benefit. So for example, if you've got a health plan that puts annual or lifetime dollar limits on wigs and infertility treatment, You just need to find a state benchmark plan that doesn't cover wigs and doesn't cover infertility treatment, and you're fine, because you can consider those things to both be non-essential health benefits. But let's say you're adding a new service and you decide when you put in this benefit that you're going to subject it to an annual or lifetime dollar limit. Let's say maybe you're adding transplants for the first time and you want to make a lifetime limit on that. Well, you're going to need to be sure that that state benchmark plan you picked also excludes transplants. And if it doesn't, you need to find another plan that excludes wigs and infertility treatment and transplants. So just make sure that that's on your radar if you're adding any annual or lifetime dollar limits. You're also going to want to consider the extent to which your health plan does or should cover gender transition services. Harkening back to Beth's discussion of the Supreme Court case, right now, you may not be required to cover these services. You may. There are a couple of pieces of guidance that would say that you do. If you're subject to Section 1557 of the Affordable Care Act, which generally is if you've got a health program or activity that receives federal funding from HHS, you may not be able to exclude gender transition services under your medical plan. If you're a federal contractor and you're subject to the OFCCP rules, you may not be able to exclude gender transition services under your medical plan. In any other circumstance, there's no law right now that says you must cover these services. However, if the Supreme Court comes out and says that discrimination on the basis of transgender status is discrimination on the basis of sex, then it very well may be considered sex discrimination to exclude coverage for these gender transition services because they're offered only to they're necessary only for transgender individuals. So you could think about that proactively. You could maybe revisit it when the court case is issued, but it's something you should, again, be on your radar. You're also going to want to consider coverage of mental health benefits and applications of those non-quantitative treatment limitations. Back to my discussion on the mental health parity FAQs, any plan design you have that puts a limit on treatment of mental health services or substance use disorder services, you've got to be able to justify. Two hot button items right now in mental health parity litigation are ABA therapy for autism and wilderness therapy. So it is perfectly fine to say our health plan is not going to cover treatment for autism. You can exclude coverage for a particular condition, and that is fine. That doesn't violate the mental health parity rules. But as soon as you say we're going to cover certain treatments for autism, and if you exclude other treatments for autism, you've got to be able to justify that under the non-quantitative treatment limitation rules. Wilderness therapy, for whatever reason, has become a hot item in the past couple of years. Wilderness therapy is where typically it's with operationally defiant teens. You take away their electronics, you take them out of the real world, you throw them into the wilderness, and hopefully their attitude adjusts. In some cases, that's camp. In some cases, that's education. In some cases, it's medical therapy. So if your plan simply excludes treatment for wilderness therapy, but you provide treatment for other conditions that can be treated by wilderness therapy, again, you got to be able to answer why and justify that under the mental health parity rules. And then, of course, you want to confirm any legal requirements applicable to any new types of benefits. We're seeing a trend toward employers offer maybe more non-traditional benefits like egg freezing, breast milk delivery, different things that are out there that are providing new and different benefits to employees. You want to think about, number one, is it covered by ERISA? Should it be in your ERISA wrap plan? Should you have an SPD for it? Is it something that if you cover it 100%, it could disqualify your high deductible health plan? So making sure if you're adding anything new for 2020, you understand what the legal requirements are and how it might impact the other things you're offering.
All right, and I just want to let people know that because we did get a late start, we're going to try to go until about 1:15 to make up for that lost time. I do apologize for the delay, but we're almost done, and then we'll transition to questions after that. We've got a couple questions on deck. So updates to required notices. The CHIP notice, DOL issued a revised notice July 31st, 2019. Plan administrators most likely are used to these revised notices being issued, but we just wanted to call this out for you. No updates to any of the other key notices that you send out on an annual basis. We've listed many of those notices here. And then that concludes the main portion of our presentation. We do have some questions, and we'll begin the Q&A session in just a minute. But we first want to let you know that if you would like CLE or HRCI, please note the attachment on the right side above the screen where you type in your questions. This is very important. If you want to apply for credit, you will need to print and complete attorney affirmation form available in the handout section on the website. And you'll also need to include this code. The code is TH919. That's T as in Tom, H as in Harry, and the number 919. Once again, TH919. Please take a moment please take a moment after the webinar to complete the evaluation, also available in the handout section of the GoToWebinar site. This survey will only take a few minutes to complete, and we would really appreciate your feedback so that we can better serve you in the future. So now moving on to the Q&A session, if you do have questions, please type them in your question box. We will address them as they come up, and we do have a few questions on deck. The first question is a drug manufacturer's cost-sharing program to be treated like a coupon? For example, we have been offered participation in a program in which the manufacturer will cover 2/3 of the cost of a particular drug, and the participant will cover 1/3. Should the manufacturer contribution be excluded from the participant's deductible and out-of-pocket maximum? So in general, we would say that yes, you should be treating cost-sharing programs like that similar to a drug manufacturer's coupon. While the preamble to the drug coupon regulation specifically refers to coupons, the regulation itself doesn't actually use that term. Instead, it's phrased basically to require that amounts paid toward cost sharing using any form of direct support offered by drug manufacturers to enrollees to reduce or eliminate immediate out-of-pocket costs for specific prescription brand drugs that have an available and medically appropriate generic equivalent are not required to be counted toward the annual limitation on cost sharing. So again, the question of whether the manufacturer coupon should be excluded from the out-of-pocket maximum, that would basically be applied to the same extent that you would apply the regulation to other drug coupons. So if you are, if this cost sharing is related to a drug for which there is a medically appropriate generic equivalent available, then the plan may exclude the cost sharing from the out-of-pocket maximum, but is not required to do so. Okay. And then the next question that we have relates to, we've got several questions that came in. All right. The next question that we have relates to preventive care. On the preventive care notice, any insight on how employers are responding? Are most choosing to offer those drugs at no cost or co-insurance rates?
So I've seen both ways. I've seen some employers, after talking with their administrators, say, that's too much administration. We'd rather just, make it easy. It's difficulty in communication. We're just going to keep on keeping on like we did before. Now, I've had another employer whose PBM said, we're keeping on like we did before, but that's because what we were doing before already encompassed everything that was on this list. So in that case, they had one of those prescription drug lists that covered everything that was on the IRS notice. So that administrator was intending to just continue with the status quo, which essentially built in that notice. So that administrator wasn't making a change. They thought they were already complying. I've not yet, I don't have a good sense yet of employers who think that they need to make a change and are moving forward to make that change, or what sort of additional administration is required. Beth, I don't know if you've had experience on that. No. Okay. That also takes me back to this concern about these preventive drug lists, and I'll just give you a bit of color on that. I feel like a lot of the work that we do is based on rumor in our line of work. And the rumor that I heard from somebody who claims to have been in the office when the executive order was produced and, talking with the Department of Treasury, said that the intent was for these preventive drug lists to be approved, to be essentially guidance that was already okay prior to this notice. And this notice just adds to that. Whatever the industry standard preventive care drug list was, that should be fine. I can't read the notice to say that. So I would love to see the IRS come out with some guidance if that's really what they think to clarify that.
All right, and then we have gotten a couple questions on annual limits. So one relates to New Jersey transit benefits. So regarding the New Jersey commuter benefits, the benefit must be offered at the maximum federal limit or amount. But I don't believe that the limit has been released for 2020 yet. Would we need to then update our annual limit if it is later released after annual enrollment? And we've gotten a similar question or analogous question with respect to FSA.
Mm-hmm. And so for the transit, you should know the limit before the year begins. Actually, in both cases, but I think the concern is we've communicated this already to our participants, and yes, I think for the New Jersey Transit, you're right. You have to offer it at the maximum IRS level, so you would have to update that. But the transit benefits, you can make changes generally at any time. It's not like the medical FSA where you have to make one election and then you're stuck with it. So it should be easier, I think, for the transit benefits to adjust. Plus the fact that in New Jersey, you don't have to do this until March, theoretically. But so yeah, the transit benefits I think are announced, the limits are announced at the same time as the medical FSA benefits, which likely won't be until open enrollment. For those transit ones, I believe you would have to up the limit for 2020 once that 2020 limit is announced. For the medical FSA, whether you have to update it is really dependent upon the terms of your plan. If your plan says, we allow participants to contribute up to the IRS max, then yeah, once that limit adjustment is announced, your plan is increasing the maximum contribution for 2020. And so you'd need to go back to your participants and say, well, actually now you can actually contribute up to the new maximum. And so you could consider either maybe opening another window for all participants to increase their medical FSA election to that maximum amount. You could go back to just those folks who elected the maximum FSA contribution and allow them to bump it up the $50 or whatever the increase is going to be. But that's if your plan is written that way. If your plan isn't written that way, it may have $2,700 hardwired into the plan, in which case any increase by the IRS later doesn't impact your plan. You'd have to make an intentional decision to amend your plan to increase it and then go back out to your participants and allow them to increase. I see employers do different things. Either they say, whatever the limit is at open enrollment, when we're preparing these communications, that's what the limit's going to be for 2020, regardless of what the IRS does. And I have other employers who say, if the IRS increases it, we're going to go back out to our participants and offer them the opportunity to increase. So it's completely up to you, whatever you want to do. You just got to make sure that your plan document reflects your actual practice.
All right, and then we have one more substantive question. Do the HRA regulations impact our ability to offer a retiree-only HRA?
No. So the HRA regulations were intended to address the fact that a group health plan is required to comply with the market reform rules, which require coverage of all preventive services and prohibit application of annual or lifetime limits on essential health benefits. Health reimbursement arrangements by their nature don't cover all preventive services and have an annual dollar limit. So unless the HRA is integrated with a group health plan that satisfies the rules, then that HRA is inapplicable. Well, those rules aren't applicable to plans that don't cover employees. So if you've got fewer than 2 current employees on the plan on the first day of the year, we typically refer to that as a retiree-only HRA. It's not subject to the market reform rules, and so you don't need any special guidance in order to offer that retiree HRA. You can still offer that it wasn't impacted by the regulations at all. You can offer a retiree HRA along with an individual coverage HRA. You can offer a retiree HRA along with a traditional group health plan. You can offer a retiree HRA by itself. Those are sort of completely outside the realm of the HRA problems, and so are not impacted by these regulations.
All right, and then we do see that someone has let us know, thank you, that you're having difficulty downloading the HRCI form for credit. So we will send that out after the presentation. And I think we're at a close at this point. Thank you everyone for